Hi, everyone. I'm Ross Brownson from Washington University in St. Louis, and I'm glad to be with you today. I wanted to let you know that during the session, I'll be online and I'll be glad to answer your questions live through the chat. My topic today is designing for dissemination. If you see that little image on the left-hand side, that's the search for the Holy Grail. You remember the Holy Grail is the cup or the dish that has these miraculous powers that lead to happiness and eternal youth. But more broadly, we think of it as an elusive object or goal that we seek and has great significance. I think of designing for dissemination as a pathway to help us reach our Holy Grail. So what's our Holy Grail? That's impact. That's why each of you has gotten your field in the first place, is having your work make a difference in society, eliminating disparities, and make the world a healthier and a better place to live. Our 4 goals for today are to briefly describe some of the core principles of designing for dissemination. You'll see the shorthand D4D. Learn about some of the progress we made and what some of the gaps still are. Talk briefly about some D4D methods, and then spend a bit of time on some steps and some ways that each of us can better incorporate D4D principles in our daily work. As you listen to this presentation, I want you to think about a couple of questions here. Why did you enter this field in the first place? What are some of the impacts that you want your work to have, or you hope that it's already having or will have in the future? And then, given the theme of this meeting on pragmatic research, which is so important, what makes D4D impactful, and especially making it pragmatic and action-oriented? Can you develop something that's broadly applicable? And just a couple of caveats and things to keep in mind. This is a very brief introduction, basically a 30-minute introduction to D4D. You can dig deeper into almost any of the topics I'll talk about. It's oriented primarily for practice audiences. By practices, I mean people working in clinical settings, so a clinical practice, people working in a state or local health department, or people working in a non-governmental organization. It's less of a focus on what I call big P policy, that is legislative policy, laws, the laws and regulations in democratic society that govern daily life. In big P policy, there are some differences. What counts as evidence for a legislator is likely different than what it counts for you. The outcomes are different. So the outcome in a legislative D4D study might be passing policies, passing a new law, changing reimbursement policies if you do clinical care. And then you might be familiar with John Kingdom's policy streams and policy windows, that, you know, policy consists of the problem, a policy, and the politics, and windows open and close. So we're not focusing so much on big P policy, but many of these same principles apply, just in a slightly different way. And in the context of this meeting, of course, we'll be circling back to what makes D4D pragmatic. Very quickly, and you've learned about some of these already in the meeting, dissemination is an active approach for spreading an evidence-based practice, basically. Thinking about a channel, thinking about a way to do it. So a channel might be mass media, it might be discussion with clinical leaders, but doing it in a very thoughtful and impactful way. It differs from passive diffusion, where we put a new innovation out there and we let it diffuse. Designing for dissemination is slightly different. That is the process for ensuring that an evidence-based practice, a policy and intervention, is developed in a way that fits with the needs, assets, and timeframes of an adopter. That might involve how we package an intervention. It often involves working very early with end users, working with them often, and making them really an integral part of your study. Well, what about progress? I'm going to talk briefly about why we haven't done as well as we might do. And there's 5 pieces of this. The first is our assumption that passive diffusion or passive dissemination works, the lack of connections between the generators and the appliers of knowledge, so the people who are doing the research versus those who use the research to change practice, how we disseminate, what we value in the academic enterprise, and then whose job it is to disseminate. And so I'm going to briefly hit each of those 5 pieces. On the first one, passive dissemination, or sometimes called diffusion, is largely ineffective. So if you have a new finding of a new study, you get it published, it's a randomized trial, you get it published in the New England Journal of Medicine, and suddenly that publication is going to change practice, it's probably not going to work that way. It might change practice for 3 to 5% of the practices, but for most it takes more. We need to frame information differently. We need to segment the audience. We need to think about social influence, especially those in a clinical practice who are opinion leaders, and we need to provide better incentives and reinforcement. Every one of those bottom 3 bullets I'm going to return to in some form or another through the rest of the talk. Okay, so I'm a baseball fan. Hopefully some of you are baseball fans, maybe the Rockies, maybe another team. This is the real field of dreams. And this is just the idea, you know, from the great baseball movie, Field of Dreams, if you build it, they will come. Well, we've always thought if we have evidence, if we build it, if we find an effective intervention, they will come or they'll use it. And we know that doesn't really happen. And so this is really important to keep in mind, especially for the baseball fans among you, which, by the way, mid-August, we're going to have the Cardinals and the White Sox playing a real baseball, a professional baseball game at the Field of Dreams in Iowa. You can also think of this as the push-pull dilemma, you know, why we're not connecting better. The cartoon says, trust me, Harold, it's not or demand, it's supply and demand. So we always have to think not only but of the supply of the search, the science over here on the left-hand side, the market or the pull over on the right-hand side, and the market here might be a clinical practice, it might be a public health agency, and then the connector in the middle is often what's missing. That is some group, some person, some team, some enterprise that's connecting the generators of evidence with the users of evidence. And this connection is important. And a researcher often focuses more on the left-hand side, and a practitioner often focuses way too much on the right-hand side. And I want to credit my colleague, Tracy Arleens, formerly of the Robert Wood Johnson Foundation, for this excellent idea. Well, what do we know about disseminating evidence? What do we know about how researchers think about dissemination and how practitioners also receive information? This table, quite a lot of numbers in here, but I'll highlight a few. The column on researchers is a large survey of mainly public health researchers, but also some clinical researchers. The question to them was, how do you most effectively disseminate your research to non-research audiences, particularly public health practitioners or clinical practitioners? The next column are local practitioners. We asked them, how do you most often learn about the latest research? And then the same set of questions for people working in state public health practice. I want to illustrate a few issues here. Well, of course, publish or perish. Researchers always think about academic journals. We always think about that as an effective way of disseminating our evidence. The number one way local practitioners learn about research is through seminars or workshops, and the same for state level practitioners. Now let's go to the second one. Academic conferences, a meeting like this one, for example. Way down on the list, for researchers, in fact, it wasn't noted at all, are professional associations. That's the second most common for local practitioners. And then up at the top, the state level practitioners, their second most common way of learning about the latest research evidence is through academic journals. And then we'll go to the third, reports to funders. The third for local and state practitioners are both some version of an email blast, a listserv, something getting out in a wide range. So what does this show you? It shows you there's a disconnect between how researchers are disseminating their information and how practitioners are learning about it. All right, so let's look at a little bit of different data. These are data that look a little bit more at dissemination methods. And this is data collected from the group there at University of Colorado, led by Chris Nepke. And here, this is a study of both clinical and public health practitioners both in the United States and Canada, a sample of about 210 researchers. So this is from the research side. They asked about what are the most common ways that you disseminate your research to non-research audiences. And you see them there in rank order: academic journals, reports to funders, face-to-face meetings, seminars or workshops, social media, and press releases. What has the most impact on your career? Here, you see high impact on the career from academic journals, but much less impact on practice and policy. And this is probably accurate, I think. And then the next one, face-to-face meetings, had a very negligible, in fact, nobody said that has made an impact on their career, but really important for practice and policy. So what we have to think about is this disconnect about what we're taught to do in academia, what we see as valuable, may be very different than what's valuable out in the practice world. So it's really important to keep this in mind. Well, this is kind of the publisher perish cartoon. Yes, a trivial observation, but fodder for at least 5 papers. What we know about impact in academia, just as in the previous slide, what users of evidence value is different than what generators of value of evidence value. We tend to privilege innovation. We tend to devalue replication, dissemination, and implementation, which is obviously a very major theme of this meeting, why we need to put greater value on that. And then accept in pragmatic research external validity, how we generalize to different populations, is often secondary and sometimes left out completely. So very important to keep that in mind. Wanted to mention one other, and that is this idea that it's important, but it's not my job, or I don't know how to do it. This is data that was collected, both quantitative and qualitative data, from a conference now almost 20 years ago. To me, at least, the first Designing for Dissemination conference that I know about. They gathered together researchers and practitioners, both from Canada and the US, and they asked them questions about whether the ideas of D4D were important, and then who should do it. All audiences, all the researchers, all the practitioners, both countries thought it was very important, and nobody took responsibility for it. So that's very important. If you think back to that push-pull diagram, having that connector in the middle is really important. And I'll return to that in just a few minutes. Well, a little bit of data now on what we know about D4D. Most of you in the audience are researchers. So here we've got data from public health practitioners on the left side, from a mixture of public health and clinical practitioners on the right. This is simply, is this an obligation for researchers to disseminate their findings to non-research audiences? And you see that the majority strongly agree, and if you put together the strongly agree with the agree, we're up around 87 or 88% in both studies. There is a little bit of improvement from 2013, when that first study on the left side was done, up to 2019 in roughly a 6-year period, but it's not a significant improvement. We also have Canadians in the second study, and so that might partially explain, because you'll see in a minute, Canadians tend to do better at this than the US does. Well, the next question is, how often do you involve stakeholders? One of the key principles of D4D is that we include a number of different stakeholders, practitioners, policymakers in the process. And you can see here that about 34% always or usually involve stakeholders, 49% sometimes or rarely do, and 17% never involve stakeholders. So it's important to keep that in mind. Obviously, lots of room for improvement here. In clinical research, the PCORI projects have really mandated a lot more practitioner involvement and patient involvement in the research process. So that is probably, among PCORI researchers, this would look much different. Okay, so what methods are being used? So in other words, from this slide, if I'm working in this always, usually, sometimes, rarely side of things, how am I doing that? And down the left-hand side, you see a set of 6 ways that we can more involve practitioners, decision makers in clinical and public health practice in D4D activities. And you see focus groups, advisory committees, user panels, making them team members on the studies, asking them to help interpret data, and asking them to help us actively disseminate data. I'm just going to point out a few key parts of this. You know, there are a few places where there's differences between the clinical and the community practice, especially for advisory committees. Clinical researchers tend to use advisory committees a little bit more than people working in population settings. To me, that was surprising, actually. And then another interesting part of this is overall, you look down this list of the Canadian researchers versus American researchers, all the way across the board, Canadian researchers are doing better. And so what does that mean? We don't really know for sure. We think it's probably how the research is funded, how it's emphasized, probably how people are trained. Maybe there are more people who have worked in practice in Canadian settings. But it's important to keep that in mind and really remember that there are some pretty important differences here. We also ask people to self-rate how well they're doing. So in other words, are you doing an excellent, good, adequate, or poor job in reaching non-research audiences? And you see here, I think people are probably pretty honest. We group together excellent and good, 30%, adequate is 35%, and poor is 35%. So here, people want to do better. There ought to be some ways to do better, and we'll get into that in just a couple of minutes. In a paper here cited, the Rachel Tabak paper that I cited here on this slide at the bottom. In Rachel's work, she looked at what would predict being an excellent disseminator, and I put in here the odds ratios that are statistically significant. If it's important in your academic department, you're about 2.3 times more likely to be an excellent disseminator. If it's expected by your funding, that makes a difference. And then the biggest odds ratio by far was having previously worked in a policy or practice setting. And as a side note, those who were employed at NIH, which are part of the sample, were the least effective in reaching non-research audiences. And in a way that kind of makes sense because, you know, the NIH is a large research enterprise. These are intramural scientists at NIH, people doing their own research at the NIH. So that's just important as a backdrop. You probably heard this quote: the definition of an insanity is doing the same thing over and over and expecting different results. From Albert Einstein and credited to many others, including Ben Franklin and Mark Twain. So the notion here is we need to do better. We need to do some things differently than we've done them before. And that's where D4D really requires really some new tools, some new approaches, some new ways of funding things, and just in general, a different orientation to how we think about the research process and how we use research. So I'm going to conclude with basically 6 ideas on how we might improve. Keeping in mind that there's probably not a single project where all 6 of these ideas apply, but I really want you to think of this set of 6 as sort of a menu that you could choose from. And think about which ones might apply for you, and then of course, chat any comments or questions to me as you're thinking about these. First one, and I've already touched on this one, dissemination does not occur spontaneously. We need to make it more propulsive, more active. We need to make sure it's someone's job. For most of us who work in academic institutions, we have someone who can write our press releases, which is probably by far the most common way that academic institutions disseminate and try to reach non-research audiences. But that's not segmenting the audiences. It's not a very focused way of doing it, and to reach, let's say, a practice audience is probably not very effective. The second one is how you fit in these D4D principles in different parts of a project or grant application. Does it define a certain set of activities? Do you have the right set of expertise put together to be able to carry out D4D? are the interventions you're using, and I put on here the National Cancer Institute's RTIPs. RTIP stands for Research Tested Intervention Programs. I put the web link here. In RTIPs, they rate the dissemination capability of different evidence-based interventions. And so that's a useful way to think about maybe something is very effective, but it's very hard to disseminate because it requires a lot of resources and a lot of technology. This helps to overcome some of those challenges. Think about across this project where you might put in D4D principles. It might involve processes like engaging stakeholders, including feedback loops and different processes that kind of the idea of continuous quality improvement. It might include what products. Of course, we're going to do journal articles, but what about user-friendly summaries? What about step-by-step dissemination guides or a toolkit? What about business models where businesses are very good at marketing and audience segmentation? Why not use one of those? And then also thinking about D4D as a process, we need to have outcomes. So what's a successful outcome of D4D? Is it downloads off a website? Is it people have used the information? Is it actual changes in practice or policy? And just like any other part of this, we need to use the data up front to identify how an audience is segmented and how different processes can be designed for those segments. And that often is a kind of an intermediate outcome. My colleague Matt Kruder, and this is a chapter in our D&I book down below, Joe Steenman, Matt Kruder, they talk about a user-centered, a user panel approach. So if you think about over here on the left-hand side, we've got tested interventions that have gone through some process. Over on the right, you've got the users. In the middle, think about American Idol or The Voice or some competition where you've got this panel. And you've got the panel who's helping us decide what's appropriate, what the timing is, how do we design it in a way that the users can do it. And then you hand that off to a design and marketing team. They tailor it in the right way. And then it moves toward dissemination and the concept of field agents over on the right, which kind of links back to the old idea of agricultural field agents, which is a core element of diffusion theory that Ed Rogers originated back in the 1960s. So I won't have time to go into this in detail, but it's a very interesting approach how to think about this D4D process in a different way than we typically do in our usual research processes. And of course, we want to make it pragmatic. We want to use pragmatic frameworks. Tracy is one that has been featured through this meeting that can be very useful. We want to avoid the trap of focusing only or mainly on biomedical outcomes, which tends to be what a lot of our funding agencies want us to do. And it doesn't mean you don't measure those, but biomedical outcomes are probably less important for a clinical leader or a public health leader. We want to engage stakeholders meaningfully and respect their contributions. We want to design messages differently and package it in a way that's appropriate for the audience. And then it's the same idea, making it pragmatic and making it very intentionally a part of your research. Third one is this one of stakeholder involvement, which we've talked about quite a bit already. Involving them all along the way. How do you operationalize that? Well, you might involve a practitioner as one of your co-investigators. You might involve them as an advisor. You might figure out what the appropriate way is that you get meaningful input while still respecting their time. The saying used in community-based participatory research is often nothing about us without us. This engagement across a participatory continuum. Here's a framework that I like that came from Mary McKay, who's the dean here in my school at the Brown School. And this takes you across the research process, leading all the way from your study aims on the left to dissemination on the right. And then on the left-hand arrow, from lower collaboration to higher collaboration. So at the bottom, you see researchers define it, or things defined very collaboratively. And so of course, something that is more participatory is going to be at the top level here. And you want to think about at every stage of your research, how are you involving stakeholders? What makes sense at the time? And avoid only using the bottom part of this where researchers are making all the decision. Some of that can be thoughtfully done with team principles, with sort of putting together the operating principles, sharing leadership, sharing resources, sharing power and decision making, and all those points can be very important. Another way to improve can involve the process, and I've sort of already alluded to this, is targeting the process better, identifying audiences, how they receive information, how it can be tailored, which is often the opposite of a journal article, which is only set for one audience in a very focused way. So I like this little planning matrix when I think about audiences. And so I just put an example in this one, public health practitioners. You want to reach public health practitioners with some of your research findings. What are the characteristics of this group? They're committed, they've got a range of backgrounds, they're not all going to have the same training, they have access to summaries, but they often can't get the original research, and they've got time urgency, probably more time urgency than almost any researcher. What are the messages? Make a difference, improve health, build more resources, and then how do you reach them as the channel? So every time you think about reaching some non-research audiences, I'd encourage you to think about a matrix like this, to think about what is it about that audience, have them help you fill this in. Don't fill this in yourselves. I happen to have been a public health practitioner earlier in my life, and so I've got that still kind of in the fabric of me. And then think about our messaging. So how do we message? So a journalist or a web designer, I like this, what I call the 3-30-3 rule. And the first three is you've got 3 seconds with a headline to capture people's attention. Here's the headline: child's life expectancy being cut short by obesity. You want to grab people enough that they then will spend 30 seconds reading the first part of the article. Here, for the first time in 2 centuries, this generation of children may end up with a shorter lifespan than their parents, according to a new report, and the rapid rise in childhood obesity, early onset of diabetes, other chronic health conditions, and if left unchecked, could have shortened the lifespan by as much as 5 years for the current generation of children. So in that 30 seconds you'll take to read that next paragraph, and then if you grab their attention, they'll spend about 3 minutes reading the full story. So that 3-30-3 rule is a helpful way to have us think more creatively about packaging. At a clinic level, how do we make approaches time efficient, consistent with the organizational climate and culture, the skills? In Ed Rogers' work in Diffusion of Innovation, he talks about things like relative advantage, cost, easy to implement, the timing of when things come into play. We have now good measures of how to measure organizational climate and culture, so that can be very important. And then the sixth one, think about things that will help tell your story better. We know about what's relevant to academic impact, what gets you promoted, what gets tenure in your academic setting, but how do you turn that into a story? How do you make it a bigger part of your training, of your mentoring programs? Avoid sort of the bright, shiny trap of discovery research, I say. Not always discovering something new, but it might be taking something we already know and applying it in a new and different way. And then remember back to the TABIC results that if you have practice or policy experience, you may be 4 to 5 times more likely to be really good at disseminating in non-research audiences. So that's important. And I want to show you one really cool toolkit. This is from my colleague Doug Luke. The citation is listed down below. And this is to think about benefits in a different way. This is a new framework. They developed it through our CTSA program here at WashU, and I know you have one at Colorado as well. And rather than thinking about academic impact, what about clinical and medical benefits? What about community and public health benefits? What about economic benefits? And then also thinking about policy and legislative benefits. And so there are a number of indicators here. This approach is being widely used by the CTSAs now. More and more of them are using this, called the TSBM, the Translational Science Benefits Model. And they provide templates and workshops on the website. They provide case studies, and they provide domains with indicators if you want to measure progress, especially in some of these bullets that are listed down below. This is the web portal, and it's growing and building all the time. They're trying to make it more and more interactive, so I'd encourage you to visit the website. And then I'm just going to conclude with a few readings. I've put together just a couple pages of some of the key readings that I built into this talk. There are many, many more, but this is kind of an entry point into some of what I think are some key readings here, and a lot more. And then I'll just conclude by a thank you to you, first of all, the audience, for listening. I hope you've enjoyed the meeting, and I'm looking forward to hearing more from you. Feel free to follow up with me. I'm easy to find. And I want to thank colleagues Russ Glasgow, John Kerner, Bethany Kwan, Doug Luke, Borshika Rabin, and many others who helped me shape this talk. Thanks very much.